This week on Empowering Midlife Wellness, I'm talking again about hormone replacement, and this time in respect to its association with heart disease, specifically the type of heart disease that gives us a heart attack, because that is the number one thing that will kill us, women as well as men. So we want to really think about everything that we can do to reduce the risk of that disease, and we'll be talking about whether estrogen reduces that risk or increases it. Let's find out. Hi friends, and welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist and certified menopause practitioner. For the past few years, dedicated 100% to taking care of women in perimenopause, menopause, and beyond. Women just like me who want to feel great now, and also do whatever we can to build the healthiest elderly version of ourselves. So everything I talk about has something to do with that. And today I'm talking again about hormone replacement, or what we now call menopausal hormone therapy, specifically focusing on issues to do with hormones and heart disease. Now, when we talk about heart disease, we're really referring to the type of heart disease that will give us a heart attack. We're 10 times more likely to die from a heart attack than from breast cancer. So 1 in 30 risk of dying from breast cancer versus 1 in 3 risk of dying from a heart attack. So it's really important to think about what we can do to reduce our risk. And when we're talking about heart disease in this context, we're talking about the type that causes blockage in the arteries that supply our heart, and in doing so can cause our heart to stop working. And so about half the time, the first symptom that we have as women with a heart attack is sudden death. So it's a serious condition that many of us are walking around with, and we don't even know it. So let's go back to talking a little bit about the history of how we developed this idea that estrogen might be bad for the heart, because it's not. So how did this happen, and what is the current view scientifically of how estrogen in particular is related to heart health? Well, a little bit of history. Back as early as 1900, estrogen was used to help women with hot flashes, night sweats. It was found to be beneficial to treat women for menopause symptoms. And in the 1940s, Premarin, pregnant mare's urine, was developed as a drug that was sold like hotcakes to women everywhere because it did make women in perimenopause and menopause feel so much better. So horse urine was found as a very reliable source of getting masses of estrogen for not very much money. And at the time, it was all we had. So women were taking it and feeling great. Doctors were prescribing it like candy because it seemed like a really good idea. And a few decades in, it was found that if you took Premarin by itself, it increased the risk of uterine cancer because estrogen does cause the uterine lining to grow. So then the decision was made to put something in there that prevented uterine cancer. Now, progesterone would prevent uterine cancer, but at the time, Provera, which is a synthetic progestin, that means it acts like progesterone, sort of, or it certainly acts like progesterone in the uterus, so it does prevent uterine cancer. And then we had the drug called Prem-Pro, and that's what was used for many years because that was all we had. Well, as time went on, it started to become evident that women taking estrogen, either kind, seemed to have a lower risk of heart attack, amongst other things. Also beneficial for their bones, and it seemed like it was reducing colon cancer. So looking back at these women, it seemed like there were a lot of health benefits. So in the 1980s, a number of big studies were done looking back at women who'd taken hormones. So these are called observational or epidemiological studies, where you look back in time at something that's happened and try to see if a certain intervention made a difference. Well, it looked in those studies, like the very well-known Nurses' Health Study, that there was a big difference and that women on hormones did have a lower risk of heart attack. But because these type of studies are not particularly reliable, because you can imagine there's a lot of other things that could affect an outcome if you're looking back in time. A very common one is what we call the healthy user bias. So there was a thought that, well, maybe the women in this study had a lower risk of heart disease because they were nurses. They were already healthier. Perhaps they were already taking better care of their health. So to see if this was actually true, the Women's Health Initiative study was developed. And that was a different type of study called a randomized controlled trial, where you take people and you give them one intervention or a different one, along with a placebo in both arms, and then run it over time and see what happens. So with a randomized controlled trial, you're much less likely to have that type of bias because you're instituting the treatment in the beginning rather than looking back on it in the past, if that makes sense. So the Women's Health Initiative study was developed to see if there really was a decreased incidence of heart disease in women who took hormones. That was the primary goal of that particular part of the study. There were other parts of the study looking at other health metrics, but the part regarding hormone replacement was really developed to look at that question in particular. So they got the patients and they put them on the medication, either Premarin and Provera if they had a uterus or Premarin if they didn't, and off they went and they started taking it. Well, as we know now, a very famous story that I've told many times, in 2002, so 22 years ago, 5 years into the study was stopped because there was a concern about some risks. We all know about the concern about breast cancer, which is now shown not to be true. And then there was a suggestion that the women taking estrogen, either kind, may have an increased risk of heart attack and stroke, which was very surprising given everything that we'd been taught in the past. And I remember as a young doctor, I was a couple of years into practice just being shocked. Like, how could that be true? Because we'd known all of my career that estrogen was positive for the heart. So this was all very surprising, and it didn't really make sense. Well, turns out it didn't make sense because it wasn't actually accurate. If you look into it a little bit more, and so this came out as a press release without any ability for people to look at the study or dig into the data. But as time went on, of course, that's been done now for 22 years. What actually happened in that study is the younger group of women, so the women who were under 60, taking estrogen or Prempro, either group, actually had a significantly decreased incidence of heart attack. Nobody talked about that part. And the increased risk of heart attack only happened in a very small group of women and only in the first year of the study, which was very interesting. After the first year, a few women had a heart attack the first year. This is true. Now, remember, they were older women, average age of 63, with lots of different health conditions. So some of them, it turns out, were coming into the study with pre-existing heart disease. So it seems like those particular women who already had plaques built up in their coronary arteries, when they took estrogen, this particularly Premarin, had a slightly increased risk of having a heart attack in the first year. Well, after that, the risk disappeared. Well, why is that? Well, the thought is that Premarin is really inflammatory. It's known to increase multiple inflammatory markers in the blood. It's not good for platelets. It's not good for lots of things. And so it has particular inflammatory properties that could cause an existing plaque to be released. Now, subsequent studies that have been done using estradiol, which is the type of estrogen that we make in our own body, has shown no such association with heart disease. So the thought process is it's Premarin that caused that increased risk in heart attack in the first year in that study, and only if the patient had pre-existing heart disease. So what we've learned from that is even with Premarin, which we would not give you anymore, taken by mouth, which we would not do anymore, everything seems to be fine so long as you don't have pre-existing plaques in your heart. And then furthermore, if you take estradiol, there's no such association between heart disease, even in the first year, heart attack, any association whatsoever. So we don't take Premarin, we don't give it by mouth. And hey, it's a really good idea to be evaluated to see if you have heart disease before you start on any medication. So I'm going to talk to you about the way we evaluate to see which patients can start on estrogen at any age. Because remember, there was really no concern for women who were under 60. And this is how this whole timing hypothesis came about. Because of that, a lot of statements were made like you shouldn't start it when you're over 60, any hormone replacement. So it got extrapolated to every kind of hormone replacement, which really shouldn't have been. And also that you had to stop it at 60 or that you couldn't continue it past a certain number of years. A lot of different recommendations were made based on that single finding in the Women's Health Initiative. And it really shouldn't have been that way because we were extrapolating from a drug we don't take anymore to a patient population that's not like you, a lot of things that are not the same. So let's break that down a little bit. Since the Women's Health Initiative, there have been lots of other studies done looking at estradiol and the risk of heart disease. And pretty much unanimously, they've not only shown that there's no increased risk in heart attack, but they've shown a decreased risk in heart attack, particularly when you start it early. And not only that, but a decreased risk in all types of death. So all-cause mortality is decreased. Now, this is where it gets really interesting. Lots of other studies have shown the same thing. And then because of the Women's Health Initiative, a lot of questions were looked into about, well, okay, we all kind of agree that starting it in the first 10 years or women under 60, we don't worry about that group. But what about starting it in women who are over 60? So there was a particular study that looked exactly at that question. And it seems to be the case that starting it early is beneficial. So if you start, and we're just going to talk about estradiol. Now, it's even the case for Premarin, but we're not going to give that to you. Taking estradiol in the first 10 years after menopause, sooner the better. As soon as you can start it is better. We do see a significant reduction in heart attack, and that reduction is massive, like 50%. So not a small decrease. Now, why wouldn't everybody start estrogen then in the very first years of menopause? And that's a very good question because we've established that it actually decreases the incidence of breast cancer and dying from breast cancer, as well as the incidence of having a heart attack, all-cause death, osteoporosis, colon cancer. If it started early, even neurologic decline is reduced. So there's multiple benefits of starting it early. There's very few arguments about that part these days. But what about starting it at 60? Well, a very interesting study that looked at that exact question showed that the benefit really is limited to the first 10 years. Women who started later did not have an increased risk. They just had no improvement. So it's not that you cannot start it when you're 60 or over 10 years past menopause, but it seems to be the case that we cannot tell you that it's beneficial to the heart after a certain time because the benefit of estrogen happens by preventing changes happening in the heart that start right away. As soon as we go through menopause, our blood vessels start to go through changes that are really not reversible. So we want to get in there soon and prevent those from happening. So how does this work? Well, it's thought that estradiol works numerous ways to reduce the risk of heart attack. It keeps the blood vessels more supple, so it prevents them from getting stiffer. It prevents platelets from aggregating that cause blood clots. It's anti-inflammatory. It's an antioxidant. So there's lots of theories about why that happens. But if you go a long period of time without it, and typically we say 10 years, the thought is that that damage has already started to be done, and we're no longer going to get that benefit. So yes, start it early, as soon as you can, and then we will see benefit. But if you want to start it later, it's no longer true that you cannot start it later because there's no increased risk. It's just you may not have the benefit. So why would you want to start it later? Well, I have patients who are 62, maybe they went through menopause at 50, and they were told all their life they cannot take hormones. Well, now they've finally figured out that they can, and they're still having vaginal dryness, they're still having some hot flashes and night sweats because those can last into the 60s. That patient could still benefit from starting on hormone replacement. So it's not a deal breaker that you cannot start it after 10 years or after 60 or any number. The important thing is you're not going to get as much benefit. And to be on the safe side, it'd be really wise to evaluate your heart for risk of pre-existing heart disease, just like you should do anyway when you're 60. So we've changed our tune a little bit in that way to soften up a little bit on this idea that you have to stop it or you've got to get off it when you're 60. You can't take it when you're over 60. Not really the case. That was all an extrapolation that doesn't actually make sense. So when we look at all the data that's out there, there's a system called a meta-analysis. There's a particular type of study called a Cochrane review that looks at all of the randomized controlled trials that have been done. There was a Cochrane review that looked at this subject in 2022, so it's quite recent, and it looked at 19 different randomized controlled trials. put all the results together and found a huge benefit for reducing the risk of heart attack in women who took estrogen, now particularly estradiol. Now the progestin component doesn't seem to make a difference, except to say that Provera is much more inflammatory than progesterone. So it's possible that progesterone even adds to that benefit. We're not certain about that part yet, but what we are certain about is that the estrogen component is absolutely related to a decreased incidence in heart attack if we start it in the first 10 years. And then after 10 years, it's kind of a null net neutral for heart disease. But if we can reduce the incidence of heart attack by 50%, now in the Cochrane review, it showed a decrease of approximately 50% in the risk of heart attack and a 30% reduction in all-cause mortality. That means dying from anything. That's a pretty spectacular result for anything. So what do we do with that information? Well, if you're lucky enough to be young and have the benefit of starting hormone replacement early when you go through menopause, there seems to be no question that the benefit very much outweighs the risk for almost everybody. And now we would be talking about taking estradiol, which is the same thing you've had in your body all your life. Some people call it bioidentical. That's got a little bit of a marketing term, bad name to it, so we might call it isomolecular estradiol. And then progesterone, the exact same stuff you've made your whole life, not Provera, because that's very pro-inflammatory, and it has no benefit other than preventing uterine cancer. We know progesterone's got lots of other benefits. But I'm going to stay in my lane just talking about heart disease. So if you have the opportunity to start on estradiol and progesterone in the first few years after menopause, or I would say the first few months or weeks or days, right away, as soon as you can, you're going to get the most benefit, not only for your heart, but for everything else, because we'd much rather prevent a problem than try really hard to reverse it once it's there. And that's just the bottom line with wellness medicine to do with anything. If we can prevent those changes from ever happening, that's going to set you up to be a really healthy, elderly version of yourself. Now, what about if you didn't get that opportunity? You're already 62, like the patient I mentioned, and your doctors told you all your life you can't take hormones because they didn't know what you know now. It's not black and white that you cannot start it. Not at all. There may still be benefits to you to start it, but probably not in the realm of heart disease prevention, Alzheimer's prevention. Those seem to require starting it earlier because we're trying to prevent changes that happen way before we have any evidence of disease. But we're going to evaluate you. I have a lot of patients who start on hormones when they're over 60. I always do an extensive lipid panel. It's great to do a calcium heart score, make sure your heart's in really good shape, that your blood pressure is normal, diabetes is under control, your weight's under control. Reduce the risk of heart disease in every way possible from other things, which we should do anyway. And then if your heart is healthy and you want to start on estrogen, based on an individual discussion and your particular health situation, that could be possible. It's not black and white, no. And then the second part of that question is this idea that you cannot take it for longer than 10 years. And that one is really just a giant misunderstanding. Of course, if we're trying to prevent heart disease, osteoporosis, Alzheimer's disease, colon cancer, we don't want to stop it when the risk of those diseases is starting to go up. So the idea of telling a patient they should stop their hormones at 60 if they started them when they were 50 really makes no sense. So now we know that we want to start it early and then continue it long term because the risk of the very diseases that we're trying to prevent only goes up with time. And if we stop taking estrogen, we'll go right back to square one. So taking it long term seems to be what makes sense based on all of the science so far if we're trying to prevent disease. Because it's a whole different question when we're talking about preventing disease than just treating hot flashes and night sweats. So not too long ago, it was said that we should only take hormones for a very short time in the lowest dose possible and only to prevent what are called vasomotor symptoms, specifically not giving any credence to the idea that taking hormones early actually lowers the risk of disease. And we know now that that second statement is true. So we can take hormones for the immediate symptoms and also for prevention of disease later in life, especially heart disease. So there you have it. If you start estrogen early, especially estradiol, because of all its amazing healthy properties for your blood vessels, as well as anti-inflammatory, antioxidant properties, it is going to reduce your risk of having a heart attack, and you want to take it throughout your life. And I'm going to repeat that the Cochrane Review, looking at 19 different randomized controlled trials published in 2022, showed a 50% reduction in heart attack and a 30% reduction in dying from anything. And if you could get that from the local pharmacy for not very much money, which you can, why wouldn't everybody take it? So that's my question for you. So if you like this episode, please don't forget to subscribe, share it with your friends. I can't wait to see you next week.